Evening everybody, and welcome to this meeting of the Adult Social Care Health Overview and Scrutiny Committee. Just like to start by asking, are there any apologies for absence?
Yes, through you, Chair, we have apologies for absence from Councillor Emma Roberts and also from Councillor Golby, the Cabinet Member for Adult Care, Public Health and Regulatory Services.
Thank you very much. Anybody else aware of any other apologies? No, okay. Are there any declarations of interest for any items on this evening's agenda? No? Okay. Item 3, can we, hopefully you've all seen the minutes, can we agree the minutes from the previous meeting as a true and accurate record? And you're happy for me to sign them off? Yep, lovely. Thank you very much. I'm going to put 24. Okay, thank you very much. So on to item 4, Chair's announcements. So I'm sure you're probably aware that as we're in our new home here, away from the Jeffrey room, that we are now live casting the meeting attendance. You will see there's a camera up behind me, and we are now being broadcast. So this brings us in line with many of our other meetings. So I think that's quite a nice and positive thing. Okay, so we've also had a response to the committee's previous recommendations about risks arising from the International Sponsorship Scheme for Health and Social Care, and hopefully you've had that circulated to you last week. I think it was on the 10th. And the only other thing I would like to say before we move on to item 5 is to offer my thanks to Stuart Lackenby, who will be moving on from us in the near future. So congratulations on your new role, and thank you for all the effort that you've put into this committee. Okay, so moving on to item 5. So I'm going to ask the Chief Executive of the hospital to talk to us, Laura Churchwood. But before I do, I'd like Stuart to do an introduction, please.
Thanks, Chair, and thank you for your positive feedback. I just wanted to say a big welcome to Laura. So, as people will be aware, over the last kind of 4 to 6 weeks, locally and nationally, we have seen significant pressures placed on our NHS services, and I think it would have been really honest of Laura to put her hand up and say, actually, the acutes are really busy at the moment, and as such, is this something that we could actually push back? So I just wanted to recognise the fact that despite that busyness, Laura's come along today to kind of support that conversation. I did kind of suggest a level of reprieve for Laura in doing our usual kind of PowerPoint presentations with circulation to members in advance, on the basis that this is very much an opportunity for members to get to know Laura, to understand the current kind of depiction of where we are in service delivery. But from the conversations that I've had with Laura, Laura's really willing to kind of come back to work with Scrutiny around any areas of assurance that you want to see over the kind of future years. So okay. Thank you, Chair.
Thank you very much. Welcome to the committee, Laura.
Thank you. The first test is, can I work the microphone? And I have succeeded. I'm Laura Churchwood. I'm the new Chief Executive across UHN, which is both Kettering and Northampton hospitals. I think the 2 items that you wanted me to cover are both the collaboration efforts across Kettering and Northampton, but also more widely with Leicester, and also what the hospital is experiencing at the moment in relation to winter. So I'm going to do about 5 minutes of talking maximum, and then there'll be an opportunity for you to ask me any questions. As Stuart said, I'm really happy to come back to the committee whenever you like to talk about any topic. I've been in post for 12 weeks. I really need to move into months, but it's been 12 weeks since I started the new role as Chief Executive across the county. I'm from Northamptonshire originally, and I've lived here for, I don't know, probably about 35 out of my 45 years. But I've worked in London for a hospital called UCLH for the last 23 years before coming back to Northampton to work. So that's just a bit of an overview of where I've come from. And my background is actually both operational management and also capital development in the NHS. So my last role, I built 2 new hospitals in London, which is one of the reasons why I think I'm here, because there's quite a lot to be done in relation to capital development. Anyway, I'll move on to the collaboration efforts, which I understand is what the committee wanted me to cover. So in terms of where we are with our collaborative efforts across Northamptonshire and with Leicester, I'm here. I've been appointed as the Chief Executive across both Kettering and Northampton, and we now have a fully formed executive that works across those 2 acute trusts. I think there's real benefit to doing that because it really allows me to work out how best to manage the acute pathways across the whole county, and there's lots and lots of things that both hospitals could benefit from whilst working with each other, learning lessons from one another, but also supporting what I would call more fragile services, and also just things like we've opened Spinneyfield, which is a community hospital, over winter, and that's being run by Kettering but used for Northampton patients. So things like that I don't think may have happened 2 or 3 years ago and are now happening because we're working in a collaborative way. We're also working with Leicester, and I know there was a presentation to the council perhaps about a year ago from Palmer Winstanley, which talked through some of this, so I won't go through all of it in detail. I have read the previous presentation. I think the benefits really for working with Leicester as a sort of county of Northampton is Leicester's a really big hospital. It's a big teaching hospital, lots of medical students, it's got the university collaboration, and actually it does a lot of research, and it's got a lot of those super specialist services that we won't offer in Northampton. And having an ability to collaborate across those kind of pathways is really beneficial. And also it's been really instructive to think together about how we might crack some of these really difficult problems we've got in relation to urgent emergency care over winter. Leicester have been under more pressure, I would say, on an acute basis for longer, so they've done things that we perhaps haven't done in Northampton, and that's been very beneficial for me personally in my first 10 weeks of working in the organisation. So there's lots to do in terms of collaboration, but I think the fact that we brought the 2 organisations in Northampton in particular together is going to be of benefit to patients across the county. I think it will take us a long time, potentially a longer time than I would have hoped to get to where I want it to be, but I'm really positive that we can make a difference for both Kettering residents north of the county and also residents south of the county. I do live in the south myself, but for all of Northamptonshire I really want to make it work. So, next thing is winter, which is difficult. As Stuart has outlined, we've been under enormous pressure over the last, I would say, 8 weeks. We have had 2 critical incidents that we've called, one in November and one last week, because of the overwhelming demand that we were seeing across our A&E services, so accident and emergency services, with incredibly long waiting times for both ambulances, but also just overcrowding in the emergency departments. So both of the critical incidents have been called in the last 8 weeks. I don't want to say too much, but this week actually is a little bit better. I feel a bit nervous saying that because I feel like I'm tempting fate, but the weather's got a little bit better. In the health service, it may be the same in councils, I don't know, but in the health service we always say that the worst week in terms of admissions and potential arrivals into ED is the first week after New Year, which was exactly that. Last week was when we called the critical incident, the second critical incident. So I'm hoping that things may get a little bit better. Having said that, it has been incredibly difficult, and we have been doing some things that I would not want to do, for instance, nursing in corridors, which isn't something that any of us would want for our relatives, and it's not something that I want my staff to have to do. I think, in general, what I would say, having reviewed the bed stock across the hospitals, I think we are low in Northamptonshire on general and acute beds. I don't think we have enough. I don't think I'm saying anything that's controversial there. I think that's something that's probably widely understood. But then that leads to this kind of overcrowding in areas that actually are really difficult to manage and are really awful for patients, really. So we've also done, as I said, several things to open up more capacity to alleviate that demand. The single biggest thing we've done is open Spinneyfield. That's a 65-bedded unit in Rushden. I actually think we might rent it off West Northampton Council. Do we? It's a weird arrangement, but yes, it's you guys. That's opened. We opened the first half in late August, and we opened the second half mid-November. So I think that's made a big difference because it's step-down facilities for patients who are not quite medically fit to go home, so still need some hospital care but don't necessarily need an acute bed in the acute hospitals. So that's been a positive, but I have to say it's incredibly difficult and challenging, and I did want to say thank you to the staff that we've got working, particularly in the emergency departments, because it is really, really difficult. I think what we need to do for next year is maintain a really critical focus on what we can do differently to try and mitigate people coming into the A&Es, and that's super difficult to do. It's easy for me to say, but it's really, really difficult to do. If you look at the population of Northampton, it skews slightly older, and we've also had an increase in numbers of houses being built and population increase, and I just don't think the acute services really have kept up with that growth. I hope I'm not saying anything that you don't know, but hopefully that gives you a sort of overview of where we are with winter. As I say, there are things that we are currently managing within the hospital that I wish they weren't like that. I wish we weren't having to provide some care in corridors, and I'm really sorry for any patients that have been affected by that. I think that's probably enough for me, and I'm happy to answer any questions.
A couple of things just spring to mind for me. Certainly, my first question is are you still in your critical incident, or have you stepped down from that?
We've stepped down from it. We stepped down Northampton on Friday, so it was a 5-day critical incident. Just to be clear, that is very, very unusual. Normally a critical incident would run for 24, 48 hours. So a 5-day critical incident it shows how tough it is. Kettering, we stepped down on Sunday, so that was nearly a 7-day critical incident. And
in terms of, just going back to the other point about the collaboration, one of the things historically that's happened is there's been a development of specialist services at one site or the other. Cardiology, nephrology are the two of the services that spring to mind. Working wider with Leicester, is there a thought going forward that some services may be provided at Leicester Royal and patients might have to go to Leicester, or will the patients still be able to get treatment locally?
We haven't had any conversations about details in relation to any specific services moving to Leicester. My personal view is you need to take a sort of risk-benefit analysis of what's better provided in a sort of specialist centre. And actually most services that I would consider coming under that umbrella are already in the place that they should be. But we haven't had any discussions about services moving to Leicester, no. If we do have conversations about that, we will come back and talk to you about it, absolutely.
And the current arrangement is you have a single management structure over Kettering General and Northampton General, but is Leicester off to the side as a different collaboration, or is that be an expansion that's under the same grouping?
So it's a single management team that's led by me. My boss is the Chief Executive of Leicester, and we do have a couple of executives who work across the two organisations. They're not, I wouldn't call them group roles really, they're doing big jobs across the sort of collaboration. a good example is in digital. We've got to move to the same digital platform across all of the hospitals in the East Midlands. It's not just Leicester. So actually having somebody who's going to do that at scale completely makes sense. And also our chief nurse is the Leicester chief nurse, and she's excellent and is going to bring some real rigour to nursing across Kettering and Northamptonshire. But essentially it's a separate executive team that manages across Northampton, to answer the question.
And then my final question is going back to the activity that's led to the critical incident you've just come out of. It's been known, nationally there's been a challenge with flu. There's still some underlying COVID going on. Do we think we are out of the worst of those, or do we think they have the opportunity to peak again? Because again, we saw through COVID there was constant dips, and, troughs and peaks. Do we think we might be in a trough now, and that might be it, or might there be another peak coming? What's your intel telling you?
I'm just looking at the date. It's only the 16th of January. We're definitely not out of winter yet. I wish we were. Normally, and this is normally rather than definitely, you would see activity not peter off, because frankly the emergency departments at both Kettering and Northampton are very busy all year round, but you would normally see a sort of petering off of people who really need admission, which is where the big waits are. It's not patients who are coming in and then are getting sent home, really. You would normally see that getting a little bit better in March. But it does depend on things like weather, transmission rates, whether there's something new that pops up, norovirus rates, all of those sorts of things can also impact. But it's the 16th of January. I think it's too early for me to say it's home and dry, I'm afraid.
Okay. Councillor Warren.
Thank you. Welcome. You mentioned the IT getting a joined up thinking between the hospital. Are the GPs included in this as well, GP surgeries? Because I'm not sure, but I believe there is some connectivity between the hospital and the GPs, which is not great.
So normally the hospital systems are very separate to the GP systems. That's generally across the NHS. What you need though is interoperability. So we're not going to buy the GP system because it wouldn't do what we need it to do. But what we need to do is make sure that our preferred supplier has that interoperability with the GP practices. We also need to make sure we've got interoperability with things like the NHS app, because I believe that that's one of the things that is really beneficial for patients. I love the fact you can do your repeat prescriptions on it. Like, it's all really good benefits and actually saves time, saves resource, saves patient having to ring up the GP. So we do know that we need to have that interoperability. I think some of the changes that we need to make digitally in the hospital are going to be quite big, because I don't think I've come from a very digitally enabled hospital, and neither hospital really is where I would consider we need it to be for the sort of 21st century digital landscape. But we have got a plan for it.
Yeah, I think the connectivity between the GPs and the hospitals is crucial.
Yeah.
And just the records that come from the GP that get lost between there and the hospital, the patient turns up at the hospital, nothing. It must cause huge delays in getting health, or incidents occurring at A&E. It just seems a real problem for me that's not actually happening.
The other point to note is not all GPs are on the same system, just to be
Stuart, you
more
wanted to come in?
complicated.
If I may. So we do have the shared care record in Northamptonshire. Like ourselves, our IT system in NGH is a bit archaic, which means we don't necessarily get the benefits of that shared care record. So the shared care record means that once NGH take forward and Kettering take forward their new system, there will be agreed parameters in relation to specific details that GPs record in their system, which are made available to the acutes. That same information will be available to us in the council. And the big thing for me about both the council and our NHS partners embracing digital is we start to get towards that utopia of being able to map somebody's journey through our systems. We start to be able to think about things like predictive analytics. So as we're approaching winter, based on the patterns Laura has seen in the acutes, what could we be doing differently within the community to prevent that kind of demand playing through? So it's really good to see that that is a priority, because we recognise that that's something that's going to really make a difference for us.
Okay, thank you. Sorry, Sally, please.
Yeah, Chair, could I just
Yes.
say something?
Yes, of course.
Just back up what Laura was saying about infections and things circulating at the moment. So we're really busy in the public health team at the moment. There's lots of nasties out there. And as a council, we are, messaging to residents to make sure, if they're not feeling well, they're keeping away from work, from elderly patients and things like that, So we are absolutely, just to back up what Laura was saying as well.
Okay, thank you. Councillor King.
Thanks, Chair. Welcome, Laura. Nice to meet you. Oh, that's not very good, is it? Oh, that's why. Couple of questions. So the new 65-bed unit, Spinneyfield, what percentage of people from Northampton Hospital are being taken there? And also, how long are they average kind of being held there until they're ready to go back home?
So I don't have that information of the second point of your question off the top of my head, but it's roughly 50-50 between the 60 odd beds, so it's about 30 patients a week from Northampton. It does depend on who's available to go to that facility though, so if there was a situation where Northampton was under severe strain, we would probably flex that. There's no kind of rule that it has to be 50-50. It just has been about 50-50 because of the capacity across the two organisations. They're quite remarkably similar in terms of their bed base, really. Northampton is slightly bigger than Kettering, but not by much. So actually, that sort of distribution kind of works quite well. But it really would depend on patient need. I don't think we've got everything right with Spinneyfield at the moment, and we do need to do some work, which we're going to do with the council as well, to just make sure that we're not duplicating capacity that could be elsewhere. And we've got a bit of work that's going on in the background to make sure that we're doing that.
Okay, perfect. And then second question was the NHS app you've mentioned. Stuart might correct me, or Sally, on this. Would it be possible to put a recommendation forward that we actually do drop in the sessions here for somebody to show people that probably aren't savvy with putting the app onto their phone? Could that be something we could do in partnership together?
Yeah, great. That would be a brilliant thing to do.
Yeah, and possibly social prescribers as well. I'm sure they probably do mention it, but maybe just worth reminding people on that. And my last question, you said about the growth is not matched for the increase in population. What's your kind of number one top idea that you want to try and change imminently, even though it might be a long process?
So I think I've only been in the job for 3 months, so it's difficult for me at the moment to know exactly what the number one priority would be. I've probably got about 5 or 6 that I really need to make sure we crack. I think one of the top priorities, but really this is dependent on affordability because these things are expensive, would be to increase the number of general and acute beds, because that's in my sphere of control, if you like. And I do think we've got a bed deficit across the county. However, that is an expensive endeavour. We do have space to be able to do it, but it's whether we can afford, as a collective, to be able to do that or not. I also think we really need to press on what Stuart was talking about, which is trying to keep patients out of acute hospitals. So really the hospital should be the kind of last port of call. We really want to keep patients out of hospital, not because it costs more, really, although it does. Actually, you're much better off being out of hospital and cared for at home or in the community than you are coming into hospital for all the obvious reasons. So I think that would be also something I would look to council colleagues to help with over the next year. We've obviously also got a significant financial deficit, which is clearly a concern, and we've got some quality and safety issues that I will need to address over the coming years. But I think really my job is to improve healthcare from an acute perspective, but beyond really, across Northampton, and I've just got to get my head down and do that for the next few years, I think. Hope that answers the question.
Yeah, perfect, thank you. And I recently had to attend in October. I'd been away, I got a kidney infection, but I was in absolute agony, couldn't walk. And the triaging system that you have now, where you go into the cabin, seems to work really, really well. So I think that's a great improvement.
Thank you. I forgot to mention that in my summing up. We have actually quite considerably changed the triaging in the EDs. For a variety of reasons, and we're also going to be changing the landscape of the ED in Northampton because we've been given some money from the central funding, essentially. So we're going to do an additional pod at the front of the ED. I won't bore the committee with what we're going to use it for, but essentially it'll provide a bit more capacity in the ED. I think in Northampton in particular, we do not have enough waiting space. So we've got to work out how we make that better for patients, and part of this is to work out how we do that. But I'm really glad that you had a better experience with triaging, because the team have worked really hard to try and get that to work better for patients. Thank you.
Thank you, Chair. I'm so sorry I missed your presentation because I really wanted to hear it as well. So forgive me if my questions aren't as relevant to the presentation. The first thing is that residents tell me is that they can't get a GP appointment, so end up going to A&E, which is a big issue. And the other thing, and this happened to me also, is when you ring 111 just for advice or whatever, they seem very risk averse and tell people to go to hospital. So it just seems so unfair that you've got a deficit, financial deficit, and yet it's not in your control, is it, if there are no GP appointments? And the other thing, just quickly add on to that, how is it when people are released now? Are you finding that the adult social care is ready, or is there still some bed blocking?
So to answer the first question or comment, I think it's variable in terms of GP access. So I know that from my own personal experience that my GP is great, actually. He's very responsive, and I'm a family of 5, use them all the time because I've got small children. Actually, the access is really good, but GPs are only available or open between the hours of, let's say, 8 and 6, and that's possibly being generous. So the A&E is the sort of last port of call, and you do definitely find attendances going up in the evening because of that issue, because there's lack of services elsewhere. Would I agree about 111? I probably would agree that 111 is risk averse, and you do find a lot of patients who've been diverted through 111 to A&E. But I also think we're the sort of last port of call, and we've got to work out in Northamptonshire how we can have some services that are available and open out of hours that are not necessarily the emergency department. So we've got an urgent treatment centre in Corby. Do we need the same sort of thing in the south of the county? It's those sorts of things that we kind of need to knock around a little bit to see if there's anything sensible that we could do to mitigate some of those problems. And I know that if you ring 111 and you get told to go to A&E, you're very likely to pitch up, let's face it. on the second question in terms of adult social care, I think I would say that for complex discharges, like the really complicated end, there is still a lag. I think Stuart's well aware of that, and we're working together to see if there's anything we can do to improve that. I think there are, in terms of the sort of more simple, what we call P1s, I think there's some work to do on the hospital side to make sure that our referrals to the council are smoother. But I also think there's possibly some stuff that we could do to make that a little bit more rapid as well, and that's again about working together in collaboration to come up with something that's going to work for both parties. Because I'm sure there's always the odd kind of few hours that you can shave off, let's face it. I'm not sure they'll always make the difference that we think it might, but I do agree that if you sort of take 24 hours off every patient, that should have an impact on our bed base for sure. So hopefully that again answers the question.
Councillor Humphreys.
Thank you, Chair. Thank you very much, Laura. Welcome here, and thanks for coming to speak to us. Couple of questions. Can you tell us what the waiting times were during the critical incidents in comparison to what they are now? And you mentioned that in Leicester, in terms of pressure on capacity in these difficult winter times, they've done things there that we haven't. Can you give a sort of example of things they've done which we might help our situation here? Thank you.
Yeah, of course. So I haven't got waiting times for inside the ED as of today. I'm happy to get those to Stuart so that he can share those after the committee, because what I don't want to do is give you a number that's actually not quite correct, because it will literally just be me trying to remember. But what I will say is that ambulances waiting outside the hospital have dramatically reduced. So one of the key indicators of a system under severe pressure is where you cannot offload ambulances. So you have patients in ambulances that you physically cannot fit into your emergency department anymore. Prior to the critical incident, we had a significant number of ambulances waiting to offload, and we're now trying to offload 3 ambulances every 30 minutes. So we are trying to do that rapid offload. We're not always hitting that standard, but that's essentially what we're endeavouring to do within the hospital. So the times for ambulance offload have definitely decreased over the last week, and I'd be happy to share the information with Stuart from onward transmission. That's no problem whatsoever. What was the second question? Sorry.
You mentioned that in Leicester they've done...
Yes, of course.
Thanks.
So one of the things they've done, which we have adopted in Northampton, is they've got something called an ambulance cohort area. So if you imagine that you've got ambulances coming to... so Leicester's a massive department. It sees over 1,000 patients a day. It is huge. So you imagine you've got a lot of ambulances coming into Leicester. What they've done is they've got an ambulance cohort area, which is when the ED is under severe pressure, patients are offloaded into the ambulance cohort area and looked after by ambulance crew. So i.e. it's a kind of offshoot of the ambulances, but in a building rather than on an ambulance, and then you can let the ambulance go. So you've got one crew looking after, say, 3 patients rather than 3 crews looking after 3 patients on the back of an ambulance. Does that make sense? So we haven't had to make those kind of choices in Northampton, but we have opened an ambulance cohort area over the last 6 weeks in order to enable ambulances to get back into the community, because the critical thing for me is if you call an ambulance, you need it to arrive. So we have to do what we can to make sure that ambulances are able to get off the forecourt as quickly as possible. There are some other quite technical things in the emergency department that Leicester have done, which I probably won't go into in terms of detail, but there's learning on both sides, and there will be things that Northampton and Kettering are doing that Leicester can learn from as well. It's not just a one-way street.
Councillor Sargent.
Has mental health admissions increased since COVID, or is it now getting a plateau? I'm on about serious cases of schizophrenia, etc., etc.
I wouldn't want to comment on the case mix, but in general, mental health referrals into EDs have absolutely increased across the UK. Of particular concern, I think, not in Northampton, this isn't a Northampton specific concern, would be children and young people who are experiencing crisis. I think that's something that's grown really significantly. So, yes, they have increased.
Yeah. My nephew's had a mental breakdown, a serious one, and he was referred to Kettering, which I couldn't understand. Have you got better facilities at Kettering and Northampton?
So we don't provide the mental health facility, so he won't have been referred to Kettering General Hospital unless he's been referred to a medical specialty. If he's been referred to a mental health facility, it will be under the community hospitals. So they'll have a range of different services, lots of different hospitals, and that might be why he's been referred to Kettering. I'd be surprised if it was to Kettering General, though.
Okay, any further questions? Councillor King.
Sorry, can I have one more? Because we've just been talking about ambulance service. My daughter actually applied yesterday to do the ambulance care crew. And as we've been talking about, are we fully staffed for paramedics and ambulance teams, or are we still needing to recruit more?
So again, the ambulance is run by the East Midlands Ambulance Service, EMAS. So I wouldn't want to answer for them specifically. What I would say is we're always in need of crew, let's face it. But I haven't heard any, oh, we're really understaffed and that's the problem. I haven't heard any of that discussion or conversation. But I think every area of the health service is under pressure, and working in ambulance services does mean that there is a certain level of turnover. It's the same of every health care professional and every social care professional, let's face it.
Thank you. Any further questions? Okay, I'm just going to reflect before we close off on a couple of points that people made there that I can relay some experiences to you from about how things work. Councillor Davenport spoke about 111 being risk averse. I've also had exactly the same experience with my GP's online service, which wanted to triage me for back pain into A&E. Because it said I was about to die, which I knew wasn't true, but some people would have taken that at face value. So I think there's some work to maybe done with primary care. Councillor Sargent was talking about mental health, and again I've lived experience of a young lady in my care who had a breakdown. And there were no beds for her in the mental health acute trust. So she was looked after at NGH appallingly, but for no other reason that they weren't geared up to look after a young person that was having a crisis. And she said at one point there was literally somebody just sitting in her ward watching her, was as she described it. So I think the challenge is probably more with the community trusts than with yourself, but I think it's that trying to sort of take that holistic view, isn't it? But anyway, I just thought I'd relay that on because that's some of the points that had come up. So going forward, it's what we would like to see as a committee going forward. I think as you are relatively new in post, it would probably be a good idea to invite you back at some point and examine your plans for the future, because obviously you are clearly finding your feet. Is there any specific areas that committee would like to see, or would we like to make that a general, how do you think this is going to work? I personally would be interested in seeing how things that get handed over to us, so social care, and where we are taking responsibility, so whether that increases, decreases, what the experience is there. Again, would the committee think that's a useful thing for us to look at? Councillor Bignell.
Yes, I think it'd be useful if she came back in a few months' time and told us what her priorities are then, as opposed to what she thinks they are now. Having discovered a lot more about the hospital and been there for a few months, it would be interesting what she finds when she's dug under the skin, shall we say.
just to give you some assurance, I feel like I'm finding out a lot every day. Part of my job is to find out where the issues are.
So, question for committee then is how long? Because there are two things at play here. Obviously, we have quite a full agenda coming up. We have an election coming up, so we can make a recommendation, but whether the next committee will take it up or not is a different matter. But I feel like 6 months might be a time to invite you back. Do committee feel that's reasonable? So I would like to invite you back in 6 months' time. Whether it's with us or a different administration, it will be a different matter. So we can make that recommendation that they pick that up. And I think we'd like to hear your plans for healthcare, particularly as it affects West Northamptonshire residents.
Of course, that's absolutely fine, and I hope it's been a useful session for all of you. Thank you very much.
Thank you very much for your time. And again, given what Stuart said about Okay, thank you. So moving on to item 6, adult social care self-assessment. I'd like to invite Stuart and Neil to present their report.
Thanks, Chair. Happy for this to be the Neil show.
Thanks, Chair. I've got some slides which I think are probably just about to come up onto the screen. No worries, but I'll make a start anyway. So it's been roughly about 18 months, I think, since I brought the original version of our self-assessment to Scrutiny Committee to receive comments and feedback. So just by way of a reminder for people, the local assurance framework was put in place in response to the new powers given to the Care Quality Commission within the Health and Care Act 2022, and it gave CQC the responsibility to inspect local authorities in terms of how they deliver and discharge their duties under the Care Act, including areas such as how they support people to live and maintain their well-being, the support they provide to carers, and also how they manage to provide people with choice and control when arranging their care and support. And I think it's fair to say that sort of over the period of the last 18 months, and as we sort of continue to move forward, both local authorities and the CQC are still continuing to develop their learning within this area, and I think there has been some of that's been recently sort of publicised, particularly in relation to challenges for CQC. So they're refining their approach, but I think as a local authority we're also continuing to develop our understanding of what it is that CQC actually want from us and what it is that they're looking for. So in terms of the reasons for bringing it to yourself, obviously it's a key area of interest. The CQC assessment, when it lands and it takes place, will deliver a verdict in terms of how we are performing in terms of the adult social care support we provide. But also, I think there's a key issue in terms of the potential for yourselves as Scrutiny Committee members to be involved in that assessment process. So it may very well be that CQC wish to speak to you and take your thoughts around your observations of adult social care and how it works with its partners. So if we can just move on to the next slide. So the self-assessment document itself is aligned to the 4 themes that are on this slide. So we've got working with people, providing support, ensuring safety, and then the final theme, which is far more inward-looking, around leadership, which really looks at how we organise ourselves as West Northants in terms of the delivery of our adult social care. And the block in the middle is a bit of a summary of what CQC will use to form the basis of their assessment when they arrive. So you can see that they use a number of methods to triangulate their understanding of what it is that we're actually doing and how we're delivering. So we've design a self-assessment aligned to the local assurance framework, and this is really the document that gives us the opportunity to give our own view on how we're doing and how we think we're delivering. And what it also is really helpful for in terms of that inspection process and all the things that CQC will be looking at is it's an opportunity to preempt any potential challenges in the evidence that they see and provide some explanations for us to unpick with them during that assessment process. But also, more than that, I think what adult social care directorates nationally are using the self-assessment for is an opportunity to really engage with stakeholders on where they are in terms of the delivery of their service, but also about where they can achieve improvement and can drive that continuous improvement as well. So our document goes into detail around sort of highlighting our strengths, particularly for our delivery. It recognises where we've got weaknesses, but it does so by recognising them and then outlining any plans that we've got in place to address those. And then it also starts to talk about what we think the opportunities are for the future and what it is that we want to do against those themes moving forward. I probably should just take this opportunity to sort of explain. So the CQC assessment is very different to the Ofsted inspection regime. So when we get notified for an assessment, we'll get 3 weeks to submit evidence, which we return to CQC, and then assessment can happen any time within the next 6 months. It's a lot more stretched out than people will be used to from children's services, where it's very much a phone call one day and then within a couple of days people are on site. So we've got time to build up to it, but we also need to know where we are in terms of how we're delivering and what we're doing. So if you take the next slide, which is a summary of what we've got in the self-assessment around theme 1. We talk within this theme around the community-based approach that we take to work with people and provide support to people, how we focus on their strengths and the support they can access locally in terms of determining the help that they need. And then we sort of highlight positive steps that we've made over the last 12 months around the launch of our carers strategy, the integration of wellbeing advisors within our community teams, and also our work around the discharge to assess pathway, which our colleagues from NHS were talking about previously, particularly around our reablement unit and our use of integrated dashboards to drive our performance in that area. We know that there's opportunities to improve, and we've identified areas around how we deal with initial inquiries, so how we link people up to support that's around them and do that quickly, but also making sure that we're as accessible as possible. We acknowledge that in some areas where people require an assessment, we do have waiting lists in place, and we have to make sure that we've got approaches which enable us to manage those waiting lists. And we also talk really positive about the work that's going on in terms of the implementation of our new social care case management system, which should provide us with a level of information and a level of detail that helps drive an improvement in the delivery of our frontline services. And then finally, we talk about our commitment to making sure that there's an equity across West Northants around the experience people get of adult social care, and also the outcomes that they can achieve and be supported to achieve as well. So I'll move on to the next slide. That's great, thank you. And then in this area, we talk about the support that we provide. So this highlights the work we've done to develop our oversight of the care market and a lot of the work that we've done with our integrated care system partners. And likewise to the first theme, we sort of concentrate on some real positive moves that we've made in the last 12 months around the development of our co-production framework, as well as the launch of our new care frameworks, and embedding the local area partnership model as a way of working across our services and working with partners to do that as well. We know that improving the quality of care that's delivered through our care homes is a high priority. So that's an area that we'll always continue to focus on. And our commissioning team works really hard with our local CQC partners to improve the re-inspection rate of our care homes, particularly where there's been challenges in the past. But they also make sure that they deliver that quality monitoring role, so we've got an internal assurance around the quality of care being delivered in those care homes, even if they can't be re-inspected as well. We want to make sure that we develop our relationship with the community and voluntary sector, particularly around the area of prevention, which I'll come to mention in a second, and also working towards the delivery of the Integrated Care Northamptonshire objectives that are outlined within the 10-year plan. Now, I know when committee met and there was a specific ask for us to look at prevention and include in the covering report the work that we're doing around prevention, and he's outlined, you know, this is really key to the future sustainability of adult social care. You know, so through the delivery of our local area partnership model, we've been promoting access to universal services and understanding the profile of our local areas to make sure we can tailor support to tackle health inequalities. But we're looking to move further with the development of the prevention and early intervention strategy, which is currently being worked on. Sally, I don't know if you want to add anything at that point.
Sorry. In the appendix to the report, there's the sort of prevention model that Neil's referring to. Obviously, there's a direct link there to the health and wellbeing strategy as well, you know, and that point about trying to keep people well for as long as possible and in their homes for as long as possible. So I just really wanted to refer to the diagram. And as Neil said, we are working on a sort of prevention, an adults prevention strategy. When I talk about the lapse, we're going to be doing some engagement in March as well. So just to make those links really, but I don't think there's any more. Thank you.
Then just moving on to theme 3 around ensuring safety. So this, the narrative under this part of the document looks at how people move through the care and support system in a supported way. So a big focus for CQC when they come in, and what we've seen in other assessments of other authorities, is making sure that where people's care changes for some reason, whether that's a child moving into adulthood, somebody moving out of hospital, or if care arrangements change, have we got the right pathways of support in place to make sure that people's safety is maintained through those changes, and have we got the appropriate oversight to ensure that's taking place. And then the rest of the section goes on to talk about how we discharge our safeguarding duties and our relationships with partners, which enable us to do that, primarily through our work with the Northamptonshire Safeguarding Adults Board. In the last 12 months, we've seen some real positive movements around our safeguarding volumes and bringing these under control to a level that we expect to see them at. We've got joint arrangements in place, as I mentioned earlier, with partners in CQC, but also partners in the ICB and in NHFT around making sure that we've got appropriate oversight of quality of care. And we also utilise opportunities through exercises such as safeguarding adults reviews and leader events around understanding our practice and where that can improve to really promote safety and to deliver that as far as possible. So in terms of focuses moving forward, really our big piece of work needs to be around how we support people with multiple issues and multiple challenges to remain safe and supported. So there's for people, for example, with multiple exclusion homelessness who have challenges around substance misuse and mental health issues, we have to make sure that we're working as well as possible as partners to support people and make sure that they continue to remain engaged and supported by services. We want to maintain the performance that we've seen improve over the last 12 months and go on to push that further, and also making sure that we utilise intelligence and information not only that we produce but that's available through our partners as well, to get that holistic view of the safeguarding needs and areas that we need to focus on to promote safety right across our population. And then finally, theme 4, as I said in the introduction, is far more sort of inward looking. So the narrative in this section really focuses on our structure and approach to maintaining oversight of what it is that we're delivering, and also our future planning. And then it also goes on to talk about the culture that we aim to create across the Adult Social Care Directorate, and how we work with other directorates as well to deliver what our older population need. So over the past 12 months, we've developed and invested in our learning and development pathways and our workforce, and we've also highlighted areas where we've improved our governance approaches, including the regular reports that come to these meetings and the sharing of the of performance information, which I know you get as part of your agenda setting. Moving forward, we've got to embed that strategic direction and make sure that's reflected across all of our policies. We want to continue utilising the feedback that we receive and making sure that helps us shape and develop our services further, and also harness any opportunities for innovation. So not only around data and intelligence, but how we use technology and other developments to support people to maintain their independence and live at home for longer. And I know, again, in terms of putting the covering report together, there was a request to talk about how we triangulate all this information, which will be covered in this element of the self-assessment. And as that covering report explains, we've got various ways of doing this through the use of data. We've got a regular quality assurance meeting, which really unpicks and looks at what is being delivered and the advice that's being given to people, and that stems through our work around case audits and reflective practice as well. We utilise the feedback that we receive through complaints, compliments, but also reviews that we're part of, such as our upcoming peer review on our deprivation of liberty safeguards, and as well our work with partners and our collaboration in a number of areas also gives us that in the moment feedback of how our services are being received and areas that we need to improve. And then finally we talk about training and development as being really key to this as well. And then just on the final slide, so this is just a bit of a timeline in terms of where we are with the self-assessment. So we have undertaken some stakeholder engagement, and as I've mentioned in the committee report, unfortunately the take-up for this has been really low. The comments we've received back, or the sort of indications we've received back, have been generally positive, but not enough for us to form a real sort of firm view on in terms of areas to sort of develop even further. So I think we need to go away and think about how we get how we approach that engagement differently, so we can get that moving forward, because that is really key, and again will be something that CQC will want to focus on in terms of what people are saying about the services and the support that they receive. And the other lines start to just talk about sort of where we are just in terms of sort of the document. So we'll be continuing to engage staff in terms of the content of the document, which probably should have emphasised at the start is a very sort of living thing. So we've presented in its current form at the moment, but we can still gather information until we submit it to the Care Quality Commission prior to our assessment. Then we will keep updating it, making it more robust, making it reflective of staff's views, and making sure that it's outlining what we're working on at that present time. So at the end of the financial year, we'll do a minor refresh around some of the statistical data that's in there, just to make sure it reflects the previous financial year that's taken place. And in the background to all of this, we will continue to do our work to make sure that we are ready and prepared for any notification of inspection, and we've got the evidence that's required by CQC. Appreciate that's a lot to take in and a real sort of canter through what's quite a lengthy document, but I'm happy to take any questions for yourself, Chair.
Thank you very much. I appreciate the presentation. A couple of questions from me before I hand over to committee. I was quite intrigued by your statement about you've had to change the culture. I'd like to know what you did, because I think that could be useful to be replicated among other areas where we're seeing challenges. So I think that's something I'd like to explore. But as far as people that use the service are concerned, you talked about prevent. I'm interested to know how you measure that in terms of how you know that it's been effective. If you've taken a prevent strategy, it has actually prevented that person actually requiring the service or whatever later. And I'm also interested to learn a bit about the feedback loop from this service. So are you planning this to be part of a wider piece of continued improvement? So you do this piece, which is brilliant, and there'll be output from that, and it will do A, B, and C. But I don't want you to rest on your laurels. I then want to see statistics to demonstrate that, and then, as I say, continued improvement.
So I'll pick up the questions, and I may draw colleagues in who may be a better place to sort of provide some other answers. So taking your first one around that continuous improvement culture. What's been really key, I think, in adult social care, and there's a lot of, as you can see through the work around triangulation, there's a lot of work that goes on, which is around reflecting on practice, challenging that, making sure that that's most up to date. And I think we've invested a lot of time over the last 12 months, and say we, particularly the principal social worker and our training teams, have invested a lot of time over the last 12 months around engaging people to think about the services they deliver, how they can work differently. So we've moved to the local area partnership model, so understanding what's available in people in communities, how can you support people to retain their independence rather than providing assessments, and then sort of moving through to really about understanding individuals, understanding their strengths and what to build on. And that's been done through those opportunities to share practice with each other, to access resources to continue to build that, and getting the encouragement and the support from management to do that as well, but also being receptive to feedback. So we never take complaints or negative feedback from inspections lightly, because we want to make sure that we are delivering high quality services, but we have to have a culture which accepts where there is challenge coming from those routes and is prepared to act on and implement those. And we've taken steps to make sure that we do that, and we have the conversations to do that, and we're honest and we hold our hands up, and that we track those improvements as well as they come through. So those have been some of the key things, and I'm sure if we'd got a bit, they'd talk about more, but I think those have been really, really key. In terms of the question around prevention, and Sally, I'll give you the heads up, I'll throw over to you in a minute. It is really difficult to measure. I think anybody in any local authority, in an adult social care department, will say it is really difficult to measure. So, yeah, I'll let Sally explain how it's done.
I'll have a go. So I refer to the triangle that's in the appendix. So as part of the project, what we're looking at is the numbers of residents that we've got at different stages of the triangle, and what we're trying to do is keep residents down at the lower end, if that makes sense. So if it's a conversation one and we manage to keep the resident down or take them out of the service, you know, the number of residents that we have coming into our welcoming spaces who get a bit of advice or support, and we prevent another escalation. So we've got measures like that we're looking at, and obviously the demand that Neil's described is really difficult, but we can see early signs that some of that is helping. But the other thing is, in things like the wellbeing service, we also have measures where we're actually asking residents how they're feeling at the start of the intervention. They go through like an 8-10 week intervention, and then we ask them again, you know, how are you feeling? And we've got something called the outcome star, so we can actually see that progression. So really happy to bring those measures back at some point, but you know, we're trying to sort of build into what's quite a complex picture, aren't we?
And then just on the final point around this, how we use and utilise this, you're absolutely right. My next piece of work sitting behind this now is the set of the strategic action plan that follows on from this, which will guide our service plans moving forward for the next 12 months. you're right in terms of reviewing the document. That will be done on an annual basis, because it is a really good opportunity both to understand what we need to do, but also to stand and sort of to take some time to reflect on what we have delivered over the last 12 months. And what struck me as I was writing the document was how much progress we have made and all the sort of big pieces of work that have taken place. But yeah, we constantly use the performance measures, which are a real sort of clear indication of, are we improving, and is that is the work through the self-assessment and then the subsequent action plan delivering those improvements. But then being clear about all those things I've mentioned around, these are the areas we want to focus on. We make sure that those are tracked and delivered throughout the year, and then when we get to next year's refresh, it'll be a case of, how have we done against those? What did we deliver? Is there anything missing? But also then forming a new set of priorities and constantly evolving it. So it's a cyclical process. So it's not a piece of work that we write, put on a shelf and then come back and have a guess at whether we did it. It all forms into a whole programme management approach.
Councillor Humphreys.
Thank you, Chair. Thank you very much for your presentation. Just going back to the survey, and obviously concerning only 74 responses were received, how did you reach out to users? Because out of those 74, there not a single user, which seems pretty surprising, really.
Yeah, so each of our front-facing teams was tasked with making contact with people who'd used their service over a recent period and making them aware of the survey. I have to say, on reflection, I think asking somebody who's had contact with us, for whatever reason it may be, to take in even just a range of bullet points around the whole gamut of what adult social care does was probably a big ask. And I think if we approached it in future, or what we would do to approach it in future, is look to get that feedback at the point of contact around that service that the person had received, and then collate that up rather than doing a specific engagement exercise on the whole of the self-assessment. I think we probably put people off at the start with the range of information we're asking them to comment on. So I think we've got to break it down and harness it on a much more ongoing basis. Are
you doing a sort of scaled down one? Because you mentioned you're engaging this month.
Sorry. Yeah, so we've already moved to a process of utilising QR codes that go on letters that people receive around the outcome of the support they've received, where they can start to give us feedback, and we'll start to build the questionnaires engagement off the back of that, so that we use that.
Presumably you will need some user feedback for CQC purposes, not just internally or...
Yeah, and we'll, moving forward, we'll use the co-production network that we've got in place and other engagement vehicles that are there to do that as well. I think probably what we've seen is, if we can't rely on the survey of the self-assessment to draw out that response, then we've just got to be more proactive and utilise those engagement channels that are already in place.
Thank you. And just on the risks and challenges, I think it's page 24. Yeah, it's a very honest description of the legacy you inherited. But could you just unpick, please, why the result of what's happened in the past has meant we've got the highest unit costs of care in the country for the provision of care and the lowest spend? Just how does that work exactly? Thank you.
So some of the work that I mentioned around the care frameworks that we've put in place over the course of the last 12 months have been to harmonise the costs that we pay to providers. And Stuart will probably be able to sort of comment sort of better than me, but I think previous to that we'd got individually negotiated rates, which then sort of don't allow you that consistency across the market and then sort of give you that diversity of spend. And we've taken work to address that.
So we're sort of paying over the odds, really.
I think in some cases we potentially were paying over the odds, but this comes back to our strategic intent. So if you look at where we are now, 98% of all care home placements are on our standard framework rates. in the county council's kind of push to ensure the most efficient and effective cost delivery, the previous framework rates were so low, none of the providers would actually work with them, which meant for every single person we were supporting, providers were having individual negotiations based on what they thought that person's needs cost. So you can't say we were paying for nothing because providers were doing their individual calculations. What we weren't doing is leading the market in order to say the vast majority of people's needs can be met within these core rates. So that has resulted in a legacy, which we're eroding, of high unit costs. To kind of frame where we are, when you look at us in relation to our comparator authorities, so there's 16 of them in our group, North Northampton is included, we are 15 out of 16 being the lowest spender on adult social care per 100,000 population. To get to the median spend of that group, you'd have to put £22 million into our budget. So when you look at that, we are as lean can be. There is an inherent consequence of that. So I'm going to be talking at Overview and Scrutiny tomorrow night about the forecasting methodology around adults and why we have been overspent over the last 3 years. When you're so lean, you have no wriggle room. In some of the authorities, if you imagine if you put 22 million quid into our budget, then I'd be putting my hand up saying I'm delivering an 11 million underspend this year. So one of the negative consequences of that race to the bottom in spend is you have very little ability to absorb demand outside of your forecast methodology. But what I can say is the trajectories we're on at the moment are really positive. We're even commissioning on behalf of our health partners because they've been able to see that we can get rates cheaper than they can. Thank you.
Thank you. Mine goes back to the engagement as well. So how long have we got to try and get some more? Because it is quite poor and I'm sure we could do better if we all collectively helped.
Yeah, like I said, it's a living document. So I think obviously you have to get to a point where you start to talk to people about it and say this is what the assessment's saying. But that doesn't mean that in the background I'm not already starting to collect information to go into the next iteration of the document. Essentially, we've got until that document leaves us to go to CQC to start that assessment process. That could be any point in the coming 12 months and possibly even sort of beyond that. We know that we are one of 2 authorities that haven't been inspected in the region. As I think as Stuart would probably say, that either tells you that we're next or we're probably a mile down the road. So it's a bit of a guessing game, but we have got time to do that. And even, like I say, even when we get the notification of the assessment, we still have a few weeks grace then to bolster up the self-assessment, put anything in that we think that's missing. So anything that we can be doing that you can suggest around sort of getting that further engagement, I'm more than happy to take forward.
Yeah. Okay. So we've got International Women's Day coming. Engage people.
Yeah, absolutely.
And obviously there's loads of other events that take place as well. Getting it out to, so for instance, some short-term areas as well.
Yeah, absolutely. No, that'd be great. Thank you.
Just one point to add. So we do quite well in kind of general feedback, but there is, on reflection, a real challenge around getting feedback in relation to their experience. So, for example, if I'm a man in my early 90s and I've had the indignity of having to ask somebody to provide my personal care, after that need has been met, do I want to revisit that again? No, it's sorted. So we have to kind of strike that balance between providing opportunities for people to feedback on our services against not asking them to relive what are quite difficult conversations sometimes. That being said, any engagement that we can do to get those numbers up, we would greatly kind of support that activity.
Yeah. Well, I'm happy to help support
Yeah, it'd be really good.
Community safety set. They don't know, but...
Yes. Thank you.
Thank you. Any further? Councillor Davenport.
Thank you. I'm sure we're all for independent living, because nobody, as Stuart just said, wants to have carers. But I keep banging this drum about residents that I know that are in bed and rely on carers and have said to me, why won't they let me have physio? Because if I got my legs moving a bit, I might be able to stand up. And then they were putting on weight, which, as we all know, on joints and everything is going to impact it. So I don't know how we do it. I hear what you're saying about, you know, that's great, asking people how they feel. But a lot of people have been in the system for years, and it's just this vicious circle. And the other thing that I find sad is the fact that we have facilities within our areas, what do they call it, supported living. It used to be they're little bungalows, and there's a house there for a warden, and there's a little community centre that they all used to go to, and the warden would ring them every morning, you know, morning, how are you, John, or whatever. And people are becoming much more isolated. And I think it's really sad when we have those facilities, but we're taking them away. A lot of community centres are being knocked down or made into homes because we need homes. And the other thing that I bang on about, and I'm still getting complaints about, not as much respite care in Northampton, you know, is quite a big issue.
Yeah, thanks for the question. There was a lot that you covered in there. So I think sort of taking back to where we started, yeah, I think we absolutely work with people where we can to help them to maintain their mobility and activity. Clearly, so part of our route out of hospital will be working with people to get their through a process we call reablement around starting to move and start to manage some of their care activities themselves. And we have our therapy team that goes out to assess people and do as much as they can to help people get up and move around the home. There are unfortunately going to be cases where for some people that support provides a sort of very little benefit, and that can be really challenging. But I do want to assure you that, you know, we do as much as we can, because we recognise that that's in everybody's best interest in terms of the level of support we have to provide people, but also the quality of life that people can recapture and then maintain through that support that they get. I think that the point you make around sort of engagement and that social interaction that people need absolutely will form part of that work that we're doing around prevention and sort of early intervention, and finding the opportunities and different ways for people to be connected and be supported as things sort of change. Like you say, community facilities are different and there's challenges around that, but we have to look at what we've got within local areas so we can provide that outreach support to people, because loneliness and a lack of social engagement, we know, is one of those first things that will start to tip people towards needing longer ongoing care. So it's all part of that work around prevention and wellbeing that we talk about. And you know, within our commissioning intentions, those are the kind of sort of schemes and facilities that we're looking to sort of bring forward as we see them being, you know, positive for people moving forward. And then, yeah, I mean, respite, again, is an area that we're working on, and not only for the people who receive care, but also for the carers who need that break and the support. So, yeah, I don't disagree with anything that you've said.
Have we got plans for respite within Northampton itself?
Hi, Councillor Davenport. We're currently working with 2 providers who are probably 75% into 2 new respite services. So those should go live this year, because we recognise that we have got a specific deficit. The crux of this issue is when we were a county, we had specialist respite provision that was actually sitting over in the north. When we split, unhelpfully, all of that respite capacity got used up by our colleagues in the north, which meant we had a real absence of local provision. So we ended up giving people direct payments so they could purchase respite on their own behalf, so they engage with care homes separately. But we have done a level of market stimulation now, which has meant, as I say, 2 providers have come forward, so that we should see an increase in that capacity for the future.
Councillor King.
Thank you. Just touching on the social isolation that Councillor Davenport mentioned, obviously transport links are sometimes a barrier for people being able to get to some of the warm spaces and wellbeing group that we always offer. I know in Northampton we've got door-to-door and we've got ability. Have they been involved in the engagement, stakeholder engagement?
On the self-assessment?
Yeah.
Yes, they will be, because our commissioning team went out to all providers to make them aware of the consultation. Okay. I can't tell you whether they came back or not, because it was an anonymised survey, but yeah, they would have received contact.
Okay, that's fine. Thank you.
Okay, Councillor Humphreys.
Sorry, thank you, Chair. Just going back to prevention, perhaps it's a question for Sally, really. Presumably things like the Falls programme and exercise classes, etc., that might be something that can be measured, because I'm never quite clear whether we have more than a national average number of Falls admissions to Northampton or not. There's a statistic in the report, 1,800 or so Falls admissions. I don't know whether that was last year, or again, what's the sort of comparative for that, and is that something that you are going to be able to measure? Thank you.
Yeah, so I mean, actually working closely with Neil's service, so we do still have a full service. It's still a joint service with the North at the moment. Obviously really works closely with Neil's occupational therapy team as well. The Falls data is still a challenge for us. We do actually measure that on a week, on a monthly basis. We get information about the number of admissions due to falls and things like that. There are a few data challenges, but we've still got a problem. And we also still have the Otago classes and things, so the exercise classes and things like that as part of that sort of prevention. So you could have a scenario where a resident has a fall, or is identified at risk of falling. They're supported by the full service, maybe referred to the wellbeing service. The wellbeing service would talk to them about exercising and the Otago type support as well. And so we still have that sort of prevention layer in there. Yeah.
As far as you know, are we above average in falls admissions?
It is still a challenge for us.
By how much?
Off the top of my head, I haven't got that with me. I can share that round, or I can, if you give me a second, I can probably find out. But yeah, it's still a challenge. We're still high as a sort of county as West Northants as well, and part of that is because of the demographic as well, basically.
Just a final remark around the kind of prevention side of things. Many people get really excited when we start talking about prevention in relation to levels of savings that we can achieve. And you've really got to frame, well, what is it we're trying to prevent? We can't stop Father Time's clock from ticking. So in effect, what we're preventing is crisis. the best we can do is delay the onset of people's care and support needs. I think if you look across the country, authorities have really fallen foul of sticking great big savings targets in, which have been around stripping out adult social care budget on the basis that you can reduce the number of people who are asking for support. You can delay it, but you can't change the inevitable. Unfortunately, as an area, we have a high population and increasing population of older people. That is manifesting itself in relation to increasing demand. So the work we're doing is to do as much as we can to prevent people from hitting our doors sooner rather than later. But the inevitable will be that we still end up providing support to them. And that's why it's really tricky to quantify the impact that we're having around some of this stuff.
Is it a case of, though, they will still come to us, but they come to us not in crisis?
They might not come to us in crisis, but they might come at the point where we've exhausted everything else, so they hit us with a higher care need. So you're kind of working through in financial benefit terms, would we have been better off kind of providing a low level of support for a longer period of time, as opposed to nothing because we've done really well on preventing a fall, but when they do, they've had no supporting whatsoever, so then we're in at super high levels. It's really difficult to define the financial benefits attached to this. What we do know is it's the right thing to do. If we can support people to be independent within their own homes for as long as possible, the quality of life is maintained for as long as possible. That doesn't necessarily translate across to financial benefit.
If I give you an example, if you were to look at someone who was at risk of a fall because of, for example, say arthritis, it's making elementary adaptations like rails that they will need anyway, but it would stop that person falling. And I know if that was me, I'd rather not go into crisis, even though I might have to accept at some point I would need the care of the service. And it's about that kind of adaptation.
It is, and we do provide those kinds of adaptation, but we tend to do it in a reactive sense. So there will usually have been something which will have alerted us to the fact that that person's starting to struggle. Now, the exciting bits is, so because Sally is mobilised into our community social work teams, some of the staff who did our social prescribing to really focus on prevention. From an innovation perspective, we're looking at predictive analytics in order to look at how we can derive data from a whole array of different sources to give us an early heads up on, let's say, you, Nick, in 20 years' time, getting a diagnosis of osteoporosis with your GP. We have a data sharing agreement in place with that GP, which gives us an information line that allows us then to get in touch with you to say, hi, Nick, I hope you don't mind us getting in touch with you. We're aware that you've had a recent appointment with your GP. It'd be really good if we could come out and have a chat because there's things we might be able to do to help you keep independent within your own home. The mobilisation of that is a different level. There are a whole host of data issues attached to it, particularly when people consenting to their information being shared. But as long as we keep operating from a reactive perspective, we're not maximising the opportunities to really prevent some of this stuff from happening.
So I can see AI being pivotal to this because you could look at a whole range of information that a human doctor would find difficult, but you could say, oh, you have a family history of X, therefore you have a propensity to this particular condition, and oh look, you're on this particular drug, which it might react in a certain way. Okay, so I'm going to put you on the spot now. Okay, you talk about that innovative stuff. How far away in time do you think we might be from realising some of that?
It's one of the pilots that's included within our current pipeline for innovation.
Sally, did you manage to get the information you were after?
I hope you're impressed. So, so we're on amber. So this is the data from last year, which is reported. So last year, the sort of England average per 100,000 was 456, and we were on 467. So we are above the average, as I was saying. Just in terms of what that means in actual numbers for Northamptonshire, I haven't got the West Northants figures here. Over the last sort of 3 years, so 3 years ago we were on a roughly about 2,500 falls where there was an admission to hospital in the year. The year behind after that was 2,400. This year to date we're on 1,490. So, you know, if you look at the chart and when it happens, you can see there's a winter increase. You can see with all the work we're doing, we are trying to keep a lid on it, but obviously it's still a real challenge as well. But as Stuart was saying, the key is, you know, getting people active and exercising much earlier in their lives and things like that as well. So, yeah.
Councillor Davenport.
Thank you. I was listening to the place Scrutiny, and they were speaking about the active travel, healthy living, and they said about the council leisure centres. And I got the impression that they were thinking of doing, which they used to do years ago, reduce membership, because it is the money, isn't it? People just can't afford to go. So I wondered if that was all part of the plan to stop people getting worse, is to try to get them into a gym, leisure centre, aqua aerobics, to help them move along, reduced.
Yeah, so I know obviously there's recommissioning going on around the leisure contract at the moment, and I know as part of that we're looking at how we can make sure that we're giving access to leisure and to initiatives like the ones we've been talking about, you know, for those who really need it but maybe wouldn't access it. So maybe on GP referrals and things like that, somebody goes to a GP and I'm stiff or whatever. Actually, do you want to try some of this? Why don't you go to this class? But in public health, we do also fund a lot of these classes as well, which help residents to, do all the exercises they need to do falls prevention. And they're not all in leisure centres; they're also in community centres and things. So, yeah. But if you need more information, we can do that.
Thank you. Page 61.
Yeah. Thank you.
It's on page 61, Julie.
Yeah. That's getting onto my next bit.
I honestly did. I must have missed that. On page 61. Anyway.
That says about the 75 trilogy, that's for children and young people, but they did do a programme for that.
Okay, thank you very much. So if we move on to what we'd like to see as a committee to come out of this, a theme of this session has been around two things for me. I think it's been around prevention, and it's also been around engagement with the survey and the report. And the other thing as well I picked up on is you said the information is going to feed into the strategic action plan. So I think we'd need to see the strategic action plan when that is ready to be produced. So my quick question is what the timeline of that is, so we can put a timeline in around that. So I'll come to that in a second. But also around engagement, it's around, I think I've heard lots of ideas about how you could improve engagement and stuff. So again, I'd like to see a bit of a plan around improving the engagement. And whilst I take on point all the points made about prevention, I think it's pretty key to going forward is preventing crisis. So those are the things I would recommend. Again, before we commit dates to that, is that broadly committee in agreement? Is there anything additional in there? Okay, so the key question then is when. And again, I'm without sounding like a broken record, there is an election and there might not be here this year, but we can make these recommendations onwards. Is your strategic plan, would that be in place for the next potential meeting or the meeting after? What would be a sensible timeline for that?
Yeah, I think I'm happy to commit to bring that to the next meeting. It's
because
just
my
needs some
my
fine-tuning.
feeling is that the other things we would also like to know sooner rather than later, particularly around engagement, and as that was quite a key thing. So reflecting back to you, James, whether we think that's fit-inable.
Switch that off rather than on. From recollection, Chair, and turning to the work programme as it stands, I think there were items identified for the next meeting of the committee in March, but as is always the case, the work programme is not set in stone. It's what the committee's priorities were at one point. If the committee, in reviewing it, decides it wants to slot in new items and take out previously identified items, then it's perfectly within your bounds to do so. It's always intended to be the committee's judgment about how it could use its meetings and other ways of working available to it to best effect.
Thank you. Well, I would like to recommend with committee support that we ask for that to come back in 3 months, because I think there's a lot of stuff there that within our gift, as in we will still be meeting in 3 months. So I think that's a recommendation.
So the next scheduled meeting of the committee is the 19th of March. The next one after that will be some point June, July, without recalling exactly what the proposed date in the draft calendar for 25-26 is. 25th of June. So, yeah, the suggestion was made that this come back to the next committee meeting. You've just made the suggestion for in 3 months' time.
Yep. So
they're not the same thing, but it's entirely.
Well, March, if that's achievable, if Neil is able to do that, that's what I think we should recommend. 'Cause our next meeting.
So that's the strategic action plan.
I'm just thinking around Purda. When does Purda kick in?
March.
17.
Yeah, you can't say further noise.
Why?
Do we have a replacement term?
The pre-election period
Yes.
is the current terminology. As things stand, we're working on the basis that scrutiny committee meetings will still take place during March, during the pre-election period.
Okay. Because that period is about not announcing policy, isn't it? Not about preventing us from working.
Yes, it's not a complete moratorium on normal council business, even though sometimes it's assumed that that's what it is.
Okay. So we're happy with March? Yeah. Yes, please, James.
Chair, just in terms of the overall self-assessment, obviously sort of, unless we get a call from CQC and it sort of goes in beforehand, would you like that to be on the agenda to come back in 12 months with the refresh?
Yes, again, given that's kind of a bit of outside my remit to recommend that, what we can do is we could put that on what we would recommend the next committee would do, but I wholeheartedly agree with you, yes. Thank you.
Yeah. I mean, just on that point, Chair, you're quite right to highlight that it would be wrong of a current committee to think that it could lock down the entire work programme for its successor, given that the membership could change and the committee of the time should agree the work programme at the time. At the same, having said that, I think it's also worth saying that it would be questionable for the new committee to say, well, we're going to disregard anything our predecessor might have thought would be a good idea to scrutinise. So it's a balance between not restricting the new committee and the new committee also not ignoring the predecessor committee.
Thank you for the clarification. So therefore, I would say that we would put that in our work programme for this time next year. Thank you. Okay. Moving on to item 7, local area partnerships. I will ask Stuart to introduce the report, please.
Thank you, Chair. So, committee asked for an update with regards to our LAPs. So, Sally has produced quite a comprehensive depiction of where we are. the work undertaken to date, some of the key interventions we've taken forward, and then you'll also find within the slide set details around the next steps. What I would say is that if members of committee have had an opportunity to reflect upon the recently published NHS 10-year plan, that 10-year plan absolutely reaffirms the expectation around neighbourhood working. So the level of activity we've taken forward to date puts us in a really strong position pertaining to the future delivery of how NHS services are going to be taken forward. So whilst we are aware that we need to iterate and change some of the things as the next steps around the LAPS, the fact that we've got that infrastructure in place puts us in a really strong position moving forward. Jerry, happy for Sally to take you through the paper and the report?
Yeah, absolutely.
Thank you.
Apologies, thank you. So I'm just conscious of the time, so I'll take you through quite quickly, but just to remind the committee first of all that the place operating model is basically at the heart of the delivery of our health and wellbeing strategy and all the things we've been talking about tonight really. The 10 Live Your Best Life ambitions sort of thread down through our model. We use data and insights to inform what are local priorities. And the approach through the partnerships, when we wrote the health and wellbeing strategy, it was very much about trying to aim to reduce inequalities, improving sort of integration of all the different people involved at a local level, and improving engagement and co-production. So, linking to what Neil was saying as well. The other essence of the place operating model is our place delivery board. So what we've got on that board, and it meets monthly, and it has done for the last 2 years, it reflects the membership of the Health and Wellbeing Board. It's got a wide range of partners on there: voluntary sector, police, hospital, everybody you could think of that has, really important on this agenda. And what that board has done over the last 2 years is really gone from sort of strength to strength, and the getting that sort of focus on the delivery of the health and wellbeing strategy. So to be really quick as possible, but on the third slide, we've just given you sort of the headlines of the accomplishments, because I know the committee were really interested in that. So we've got 9 LAPs, they meet monthly, and we've got around 120 different members on those LAPs. When I'm saying members, I don't mean just councillors, other organisation representatives. Over the period of developing the LAPs, we've had an additional sort of 250 stakeholders involved in project delivery. We've got 60 different projects that have been delivered or are still ongoing, and I'll show you how we monitor that in a second. We've got the LAP website, which I hope you've seen, which has all the information in there about priorities, what's going on. And then just to say that just before Christmas, we held our LAP children's summits, where we, in each of the 9 areas, we brought all those partners and colleagues and voluntary organisations together, and we talked about the priorities for children for that local area, and really got a strong commitment to bring all this sort of asset, if you like, around the work that's going on around family hubs and spokes. So, and we intend to do the same for adults in March. And so, again, with everything that Neil was talking about, that gives us a chance to strengthen that. On slide 4 and on from that, we've just set out for you how we've been monitoring the progress and the performance of the LAPs. So we're using Power BI. This data links to our health and wellbeing strategy scorecards. So members will remember that we've got a shared outcomes framework that is shared by the ICS. And what we're trying to do with this is really track through all the activity to the ambitions and to the outcomes as well. I'm sorry, the slides are still not coming up on your screen, but on slide 5, we've just got the example of the sort of Power BI tool that we've been using. So if you said to me, Sally, please tell me what's happening in rural East, you know, tell me about the projects that have been linked to Ambition 3, which is, you know, the one around, you know, keeping people well for as long as possible. I would be able to tell you what projects have been going on, who's involved in it, and what's been achieved and things, and how that links to our outcomes. So it's a really powerful tool, this, and our BIPI team have developed this for us. On slide 6, it just follows what I've just said. So it gives you examples of different projects and you know, how they link to those health and wellbeing strategy ambitions. On slide 7, I just wanted to stick on this one for a little bit, because we've put some examples in there of, you know, all the different things that have been going on. So the ideas for these projects have come from the data, from the discussions in the lab meetings, and from bringing together partners to, you know, really try and deliver local projects. So if you just sort of have a look over that, we've got lots of examples that are linked to everything that Neil was talking about. So examples around dementia support, around loneliness and social isolation, you know, the Men in Sheds project. We've got examples relating to young people as well. And as Stuart said, this is basically the start of the delivery of the neighbourhood teams model, which is, you know, what the government are consulting on at the moment. On slide 8, that slide just shows you how the different projects are linking back through to the health and wellbeing strategy ambitions. And then on slide 9, we are just giving you the example of a project that was done in rural North. So we've got the detail of the project. So it was a develop a digital offer of connectedness for older people in a rural community where we've got a number of residents who are digitally isolated. And what that project did was support residents with devices, with support to use the devices. And the data that I've got here shows me who was involved. So the parish council, you know, the adult learning team, all the different teams, how the project ran, and you know, how that links back to those ambitions, basically. So you know, we're really proud of this tool. It's really, really helpful. So just final slide. Stuart's already mentioned that, you know, in this context, we are spot on in terms of the direction of travel. I just wanted to say that we are, as I'm sure some of you will be aware, we are conducting a review of this model at the moment. When we set this model up, it was funded with Public Health Reserve, and what we really want to do is embed what we've learned and make it a mainstream model now, basically. So we've got a review going on, which is, first of all, looking at the sort of HR element of it. We are also looking at the sort of governance and the relationship around the Place Board and the Health and Wellbeing Board. And the essence of that really is to make the Place Board even more so, where we, you know, challenge ourselves, where we look at partner strategies and where we look at how we're actually achieving and try and get the Health and Wellbeing Board so it's much more strategic in its overview. And then the third element really is to make sure that we are fine-tuning the model. So it's really supporting what Neil's trying to do. It's really supporting what what we're trying to do with our children and young people as well. And we're bringing in even more partners to do that. So, Stuart, I don't know if you want to add anything else, do you? But that's really an update. I'm really happy to answer any questions. I just wanted to say, you will all be aware of our colleague Julie Curtis, who's been leading this programme for us. She did these slides, I didn't do them. She's going to be leaving us at the end of this month. She's going to be retiring, so you know, we're really grateful for where she's taken us to. It's been really good, so thank you.
Thank you very much. I've got a couple of questions, very quick ones. Firstly, is that tool available to us as members to go and have a look at so we can leverage it? And then the second thing is about, do you feel that the areas are correctly aligned? Do you think there could be some tweaking and some changing? And certainly going forward to May, some of the boundaries are changing, so the membership will definitely change. It's whether what's there now will meet the new boundaries, and even without that, are they working? Are they doing their job? And do you have any intel that would suggest one way or the other?
So 3 questions there. So on the tool, I can see no reason why not. You know, why we wouldn't. Yeah, I mean, that would be quite easy to do that. No reason why not. I will take that up and we'll have a look at that. On the impact, I think, you know, obviously this was a pilot and we've learned lessons and there's some really good things, but there's also some things that, you know, we wouldn't maybe take into the new model. And I think what I really want to do is increase the strength of the focus on the things that we're really challenged on. So it's about supporting the adults' pressures and supporting the children's pressures particularly. But I think also one of the things that does come through in lab discussions as well is being able to focus on environmental challenges as well. So I think that's what we would really like to take into the new model, and that fits with the neighbourhood challenge. I think the other bit is the visibility of the residents' voice in there. So this review, as well as looking at the lab teams, it's looking at the Well Northants team, which does a lot of engagement in communities, as you'll know, focusing on problems and things like that, on challenges. We need to really tie that together a little bit stronger as well. But you know, I'm really confident that we can do that. And in terms of the implications of the boundary changes, so we are looking at that as part of this review. I think we do need to bring it all in line. The only challenge that will give us will be in some of the legacy data, but that isn't an insurmountable challenge, basically. But I think we are looking at that as part of the review.
Okay. Thank you very much, Councillor Warren.
Thank you, Chair. You mentioned the labs relying on local infrastructure. I assume you're saying that you're relying on the health and wellbeing hubs and the various spokes that feed into that hub as being the central point of delivery for the lab.
Yeah, one of the things I forgot to say, which I wanted to say, was that the sort of assets like the sort of parish councils and things like that, you know, we've got some fantastic examples of engagement and you know, where this has been really grasped. So yes, absolutely. You know, and obviously that comes in lots of different shapes and sizes, doesn't it? So yeah, but you know, right across West Northants, there's some really amazing examples of where, you know, we've got sort of community facilities or parish councils who've really engaged with this. So it's good.
Yes, thank you very much. It's amazing to hear that the 60 projects are underway. Just going back to the self-assessment report, there was mention of a set of performance metrics that are being developed, which I did, perhaps I've missed that you mentioned those, but could you just give a bit more information about that? And also, again, in the report there's talk about the challenges of home care in isolated rural areas. I don't know whether that particular challenge has been picked up by any of the rural labs. Thank you.
So on the performance indicators, I mean, I can bring more information on this back to the committee. Maybe when we come next time we could look at it. But basically, we've got different layers of metrics that we are trying to improve. So if we go right to the high level, we have our, you know, corporate plan, as you know, and our health and wellbeing strategy, where you know, there are things that we can see we're challenged with in the area. So you know, we're trying to shift that. As we go down into a lab level, we can see performance on some of those indicators. So, you know, and what we've been trying to do through some of these projects is share the connectivity with that indicator and ensure that we're trying to move that. So, you know, an example might be falls, as we were talking about earlier. It might be sort of how people are feeling and, you know, social isolation and things like that. But you know, we could probably bring that back when we bring the prevention strategy, because you know, there'll be an outcomes framework that's linked to that. But what we're trying to do is get that golden thread all the way through, and understand, because if you look in some of the labs, performance is very, very different. You know, our Northampton Central lab, is completely different to the rural laps, and the challenges are very different as well, you know. And then as we drill down within the lap, we see different performance in different communities as well. Another example might be in Northampton Central. We've got we know that we have high levels of COPD, emergency admissions to hospital. So we've got a project in there that's been trying to focus on, you know, making sure that residents are aware of how to access local services. They don't end up going into A&E in crisis and things. So, you know, that's the sort of things. The projects in relation to home care, off the top of my head, I'm not aware of a specific one, but the projects are much more about social isolation and loneliness. I think as we bring in the, you know, I was saying about the review and bringing in more colleagues into the lab model and really focusing on adults again, as we said, I think that will help us tease out more some of those sort of maybe service-based issues as well to share. So I don't know if Neil, do you want to say anything on that? But
yeah, I was just going to add on to what Sally was saying in terms of that overall approach, taking that lab approach. So we're talking about the home care framework that's been recommissioned over the course of this year. Well, that's been a framework that's been based on lap areas. So whereas previously, and in a lot of other councils, care commissioning frameworks will cover the entirety of the geography, what we're doing is embedding that approach to focusing on those areas, understanding the challenges within them, and then that's shaping what we commission and what we're asking providers to deliver. So yeah, like Sally says, it's getting that local understanding and translating that into the service offer.
Thank you for that. Okay, no further questions. So it's down to what recommendations we think, and certainly you've already offered you're going to be coming back. So my question is timeline. Is 6 months sooner, longer? What's a reasonable timeline for you to have that information?
so we're due to complete our review by the end of March. So be ready, you know, to go into a new model after that, and a new arrangements. So very happy to come back, you know, in 6 months' time to update. But also, if we can bring, when we bring the strategy, bring the outcomes framework there as well, I think that would be useful.
Yeah, I mean, I would agree with that. As if committee would support that, I think yeah, that sounds like a very sensible approach. Thank you very much. So I don't think there's anything further to add on that. So thank you very much. Thank you for your contribution. Okay, on to item 8, review of the work committee programme. Whilst Julie causes chaos by the sound of it over on my right hand side. Okay, so James, input from you, please.
Thank you, Chair. So this is obviously the standard item that comes to each scrutiny committee meeting to enable the committee to take an overview of the things it's previously said it will do, the things it may add to that, and the things that it may take out to or move around to accommodate its priorities. So, and as things stand, the committee had identified a couple of items that it wanted to look at its next meeting on the 19th of March there. So on support for unpaid carers, revisiting the scrutiny review that was reported to Cabinet midway through 2024, and on the community provision of defibrillators and bleed kits in West Northamptonshire, which goes back to an item that was originally raised and discussed at a full council meeting, I think, last year. Committee has obviously earlier at today's meeting added to that March meeting the strategic action plan relating to the CQC self-assessment. So that is something else to take into consideration as to whether the committee considers that all of those items can reasonably be accommodated on the 19th of March meeting, or whether it needs to revise the original planned ones. Beyond that, as has been frequently referred to at tonight's meeting, we're obviously heading into towards the end of the council year and have an election in between the end of this year and the practical start of next year. So with that caveat, there's also the opportunity for the committee to identify, as it has done, things for the longer term future, which would be for the future committee to decide, but hopefully informed by the view of its predecessor. So the work programme is as it's set out, with the addition relating to the next meeting of an item arising from the meeting tonight. Also to add that the next meeting will need to deal with the annual report on the work that the committee has done this year, because that will need to be agreed before the end of the civic year and before the election, and any changes that could result from that. So that's a relatively short item to be added to the agenda for the March meeting.
So my feeling is I think we can fit it in. Happy to take guidance from members, but I'm seeing lots of nods around the room, so I think we're happy with that. If you think that we have time for that, James, I think we're happy for it as recommended. I think looking forward at our programme, there's plenty to do in there for us to hand over to the next committee. And we have got some other dates on there that we've got stuff forward. So again, if everyone's happy with that.
Yeah, I think, Chair, I mean, virtually every scrutiny committee faces the challenge of there being more that it could do than it can possibly can accommodate. I think if that's a greater challenge for any scrutiny committee other than the one that deals with adult social care and health, then I don't know what scrutiny committee that is. You know, of all that, it's a pressure for all scrutiny committees. The adult social care and health one arguably has the biggest remit of all.
Thank you. So everyone's happy with that? Thank you very much. Moving on to item 9. Is there any urgent business, James?
No.
Then I will close the meeting. Thank you very much for your attendance, and I shall see you at the next meeting, planning meeting on the 24th of Feb, which is virtual, yes. A Teams meeting, and then the next actual meeting on the 19th of March. Soon we'll be in here again. This is now established. So thank you very much. Appreciate your attendance.